Welcome, everyone. This is Patricia from the International Hospital Federation. I hope you're all safe and well, and thank you very much for joining us today. We are hosting this COVID-19 webinar and live Q&A series to share experiences, good practices, insights, and recommendations from our members and other organizations across the globe. This series has been created with healthcare providers for healthcare providers, including decision makers and those involved in managing COVID-19. We hope the lessons you take away from this session will help you in facing the crisis and beyond. I would now like to introduce our moderator of this webinar, IHF CEO Eric de Rudenbeck. Eric?
Patricia, thank you very much for the introduction. Welcome, everyone. I wish you all a good morning, afternoon, or evening. It is a great pleasure for me to be introducing today's webinar that will take us to Aga Khan University Hospital in Karachi, Pakistan. The Aga Khan University Hospital is a long-standing IHF member and an active participant to our IHF congresses, and on our website you can find numerous presentations of what they have been doing over the years that is very interesting. In 2019, the Aga Khan University Hospital has received the prestigious IHF Award in Leadership and Management for its outpatient services flow management and patient experience, and I would also recommend that you have a look at that. So Aga Khan University Hospital is known as a very innovative and efficient tertiary hospital that combines most advanced care with a very strong drive to support its social mission toward the population. So with this background, you can expect and will expect to hear about a very comprehensive and effective response to the COVID. Pakistan is not so much in the international headlines on COVID, and I guess it's because the country is not among those that have been the most badly hit by the COVID. And unfortunately, the news, is always mostly the bad news that you have on the headlines. But still, I've looked this morning the level of on the Ministry of Health. It's still as a country that has faced a total death of more than 1,000 people, 61,000 positive cases, which is not so much for a 200 million population. So however, the virus is still active, and like other parts of the world, the threat of a bigger epidemic wave cannot be ignored. So we are in that situation, and let me introduce you now our two speakers for today's webinar. First, I'll start with Mrs. Hassan, who is a graduate from the University of Navarra, Spain, where she completed her advanced management program. She's also a fellow member of the Institute of Chartered Accountants of Pakistan. Mrs. Hassan is serving as Aga Khan University Hospital CEO, interim CEO, and she's an internationally known and recognized person through several national and international awards, which include the 100 most influent, impactful healthcare leaders, world and top 100 best performing CEOs by the CEO Club of Pakistan. So it means over all the industry, the Women's Achievement Award, the Institute of Chartered Accountants Pakistan, and the Pond's Miracle Woman Award. So a lot of recognitions that are very deserved. Dr. Asim Belgaumi, he's the Chief Medical Officer of the Aga Khan University Hospital. Dr. Belgaumi graduated from Aga Khan University Hospital Medical College, and he received his specialty training in the US as an American board certified pediatrician and pediatric hematologist oncologist. He has worked extensively in leading institutions in the Middle East, but and he has been involved in clinical research, system development. Now, currently, Dr. Belgaumi is the Chief Medical Officer of Aga Khan University Hospital, and he's also the Associate Dean for Clinical Affairs in the Aga Khan University Medical College. He is recognized nationally and internationally as a leader in his field and holds positions in national, regional, and global scientific organizations. He's also a member of editorial boards of scientific journals. So we have two great panelists, and the floor is yours. We are really eager to listen how Aga Khan University Hospital has organized the response to the COVID crisis. Thank you.
Thank you, Eric and Patricia, for the opportunity given to us to talk on this international platform. We are extremely grateful that this opportunity is being provided to us to talk about our response to the COVID-19 pandemic, how it has impacted us, how it has impacted the country. I would begin, this beautiful picture that you see out there is our beautiful campus that at which we are located. These pink structures that you see is the university hospital, the medical college, and the School of Nursing and Midwifery combined on this 80 acres parcel of land, on which we are housed in the smack in the middle of the largest city of Pakistan, Karachi. Our presentation will flow in a way that I'm going to talk about the overall pandemic, and Asim is then going to talk about our response to the pandemic. We're going to talk about the introduction, overview, what has been our hospital's response, how we are adjusting to the new norm, and what have been our key learnings. But first, before we get into the pandemic, let's talk about the Aga Khan University Hospital. So this is the two of us. I think the introduction has been done, so no need to talk about this. We are, the Aga Khan University Hospital is part of the larger Aga Khan Development Network, which is a group of institutions which are on three distinct components. We have the social institutions, we have the economic development institutions, and we have the cultural development institutions. And Aga Khan University Hospital is part of the social development institutions. Our hospitals are in Pakistan, in East Africa, and in Afghanistan, and Asim and I here are representing the 5 hospitals in Pakistan that we have. We got the charter as Pakistan's first private university, which makes us a teaching hospital. So we work on an academic medical center format, making Aga Khan University Hospital as the teaching site, not only for the medical college that we have, but for the School of Nursing and Midwifery. We are a quaternary care hospital. The hospital started operations in 1985. We are a not-for-profit institution, meaning that there is no owner, shareholder of this institution. All the money that is generated from the operations is reinvested for the objectives of the purposes for which this institution was formed by our Chancellor, His Highness the Aga Khan. In Pakistan, we have a composition where we have 5 hospitals, 1 quaternary care hospital, which has 800 beds, 4 secondary care hospitals, which are primarily maternal and child care hospitals. We have a nationwide network of 290 plus clinical laboratory specimen collection units and 14 stat laboratories where tests are performed across the country. And we have a network of 25 medical centers. These are outpatient medical centers that are located in different parts of the country. We, on an overall basis, we are a health system in Pakistan of around 980 beds. We were the first hospital to get Joint Commission International Accreditation, the first teaching hospital in Pakistan to be recognized and get a certification of an academic medical center, and the first clinical laboratory in Pakistan to get the College of American Pathologists accreditation. Just to give everyone a overall look into the numbers, to give you a feel of the size, we did in 2019 approximately 1.4 million clinic visits, around 500,000 radiology procedures, 13.7 million lab tests. This is, as I said, because we serve the entire country. We are present in 126 cities of Pakistan. Many people may not know on this platform. When I tell people this, they ask, does Pakistan have 126 cities? For sure we do. We are present in 126 cities of Pakistan, and we provide this service nationally. Around 21,000 babies are born in our system. We do around 30,000 surgeries and over 100,000 admissions into the hospital on an annual basis. What does Pakistan look like? Pakistan is the fifth most populated country. Our population is over 200 million people. The city in which our Karachi hospital is situated is close to 16 million. This is the official number, but some unofficial numbers even take this population number to around 20 plus million people. So this is one city of 21 million people, which is larger than many countries in the world. So we are a very, very densely populated city. Literacy rate in Pakistan is 59%. And as you see, the spending on health as a percentage of GDP is only less than 1%, which is very, very low. And you can imagine in a country where the health spending is very limited, the COVID situation has taken us by a blow to the health systems and a blow to a lot of morale in the country. This is how the COVID statistics in the country are looking like. We started somewhere in the month of March, and to date, we have 61,000 patients who've been infected of COVID. The death rate in the country is hovering at around 2%. Our doubling rate of the number of cases is at 12 days, and we are adding approximately 2,000 cases per day. The numbers initially, if you look at the curve or the graph, they are flatter, and the reason for the flat curve is that the testing ability was limited and the government had put in very, very strict lockdowns to ensure that the community spread stops. But like any developing country in the world, the discussion happened between an economic challenge and a health challenge, and of course the government had to make adjustments. And right now, as we speak, the lockdown in the country has been partially relieved. Schools are still shut, universities are still shut, public transport is still shut, but some economic activity has resumed, and we expect that the number of cases from now onwards will increase due to the easing of the lockdown in the country. What has been our response? So at the Aga Khan Development Network level, we always had what we call a mass casualty management plan. And when this COVID pandemic, we heard of it, we heard it coming to China, other countries of the world, we started our discussions at the hospital level. And on the 25th of January, which is 2 days before the arrival of the suspected cases, we set up a COVID task force. This COVID task force is chaired jointly by myself and our Dean of the Medical College. And then we have representatives, the government representative, all of these are internal people, but we created a liaison officer, a medical team was established, an HR team was established, a safety and security team was established, logistics team, communications team, finance team, and government relations team. All these teams that were set up were part and parcel of a mass casualty management plan that we had in the institution. But of course, that casualty management plan that we have in the institution was to deal with mass casualties from a flood, from an earthquake, and from some national disasters, natural disasters, or man-made disasters, and nothing of the sort of what we are experiencing as part of the COVID. And therefore, this structure that was set up had to be looked in very, very critically to ensure that all the needs that we have we are able to meet them. What we did was that under the mass casualty management plan, we have a structure which is called the Hospital Incident Command System, the short form of which is HICS. This HICS structure was initiated on 11th of March. As the name goes, if you look at this name, this is a Hospital Incident Command. So this command structure was also to deal with incidents. And as I said, incidents like floods, like disasters, man-made or natural, and nothing of the sort of the pandemic that we are currently faced with was as part of the plan. And there was a lot of new learning that we had all to go through to ensure that this pandemic, which to date, after several months of us being into this pandemic, are more questions than answers. And therefore, the structure also had to evolve to ensure that we are able to answer to the needs of the pandemic. We used to meet as a team twice daily, morning, evening, no weekends, to ensure that all the different requirements that came about we are able to address. And our learning in this was that our needs revolved around the structure that you see on the slide, and we were able to manage with this nucleus team, which had several teams at the back end to ensure that the relationships or the work that is coming out of this pandemic requirements are being done. So for example, the HR that you see here, the HR was a team which was not only looking at recruitment, it was looking at infected people, it was looking at transportation needs, it was looking at housing needs, it was looking at needs for isolation of employees, it was looking at need for quarantine of employees. With the lockdown happening, we had to run the hospital and there was no public transport that was available. We also had public contractors who were helping us, but then social distancing had to come. So the number of contracted vehicles had to be quadrupled to ensure that our staff that is being transported is safe. And therefore, what you see on the org chart here is a summary, but at the detailed level, each team had many sub-teams who were looking at various aspects and requirements that were there. We went through these structures, as I've mentioned here, from 11th of May, and this had to be concluded on 17th of April. I'm not going to talk about why we concluded this right now, but maybe as I go through the presentation, I will let you know why the Higgs structure we decided to conclude. But let's first go over a timeline. And if you see, this is a very busy slide. But what primarily we are trying to show you here is that starting 20th of January, we had the emergency alert issued. And we got our testing, the screening and testing up and about between 11th and 12th of May. We got our orange alert started in the hospital on 11th of March, and we admitted our first patient on 1st of March. So this is a complete timeline of all what has been happening at the hospital in response to the COVID. What we realized was that the nature of this pandemic is very unique, very different. And what we initially started assuming or realizing was that the nature of facilities that is required to deal with this, the nature of PPE that is required to deal with it, the fear factor that is there to deal with it, and the relationships with the government that are required to deal with this is very unique, is very different. And our teams and our structures had to be elevated to ensure that we are able to meet the needs of the communities that we serve. Because you saw on the statistical front that we do deal with a lot of patients, and our patients come to us for the quality that we provide. And also because we have these international certifications, it is very important that we, whether we are dealing with anything else or COVID, we are able to live up to the accreditation body requirements. What happened to the hospital? If you look at the two charts that are there, the first chart that you see on the left hand of your screen is our hospital, which is usually in its 80% of occupancy. Our occupancies dropped dramatically. And the graph that you see on the right hand of your screen shows how the number of COVID patients increased. And this is inversely proportionate because of two reasons. First, as I said, the fear factor. The fear factor is still there, and we are working on resumption of service, and we know how much fearful the public out there is. But also because the COVID patients required, the requirement of the COVID patients to come, to be screened, to be tested, to be admitted, started to increase. And therefore, our hospital occupancy went down, and the number of COVID patients started to increase. We went through several challenges. And to begin with, there was no verified test. And our clinical laboratory, which was at the forefront, worked on development of a test, and we introduced the first PCR-based test in the country. In the beginning of April, around 10th of April, we were able to launch that test. To date, there is no standard treatment, and therefore our internal medicine team, our infectious diseases teams, and other teams got together to work on treating the patients that were coming to us. And I'm very happy to share that we actually were the first hospital in Pakistan who treated the first COVID patient. And the first patient came to us, and the first patient was treated at our hospital and discharged. Then there's no standard medication. As I said, no standard treatment, no standard medication. There were a lot of safety concerns of the staff, because we have very limited negative pressure spaces. And so our facilities team stepped up, and what they did was they did a scan of this 80-acre campus that we have, 1.4 million square feet of constructed space we have. And they did a complete scan, and they identified spaces which were easy for them to convert into negative pressure. And so what they did was that they identified a space within our emergency department which could be converted into a negative pressure zone. We created an acute care unit, which is a high dependency unit, into a state-of-the-art negative pressure area. And because the demand of COVID patients started to increase to be admitted, we have designated a full building, which is a separate building from the rest of the campus. It has ground plus 3 floors, completely dedicated for COVID admissions. This is a private wing facility. And the reason for identifying a space which is private rooms, meaning single accommodation rooms, is based on the requirement of the disease. So we had to give up private room spaces to ensure that we are able to treat the COVID patients with a lot of safety. We had to move a lot of higher volumes, and what we had to do was on 20th of March, we actually did away with our elective admissions. We did away with our elective work, and the only services that continued in the hospital was the oncology service, the obstetrics and gynecology services, the pediatric service, and limited family physicians were available, and we were doing only red emergency cases. So our emergency room remained open throughout and is continuing to remain available to deal with any red emergency cases. Then the lockdown, when it came, we saw that the kind of PPE, because the PPE guidelines, I'm sure members are aware here that the guidelines also changed. So procurement of PPE, storage of PPE, and availability of PPE in the quantity that is required was a big challenge. And our procurement team has done a fantastic job in ensuring that the supply chain on that had to be managed. In addition, the reagents that we require and the sanitizers that we require, they were able to arrange it. We had to come up with some temporary spaces in tents till such time as our structures were ready. And I'm happy to report that we now have all the COVID treatment happening in proper structures. We have a state-of-the-art screening site, which is also available. We did, due to the lockdown, since facilities had to be developed, we saw that the construction material that was required to convert our spaces into negative pressure rooms, etc., it was very difficult to procure it, because the government, there was no movement of any vehicle that was allowed in the city. And we had to go through a lot of issues and challenges to ensure that our facilities are ready in time, safely ready for us to induct patients. And of course, there was a lot of fake news that was out there in the media. And I'm sure in many countries around the world, there is a lot of news that is there, but all news is not authentic news. So we had to work on the public and media relations to ensure that any misinformation about the disease and any fake news that we have about the hospital, we are able to come up with our own statements. Over to you, Asim.
Thank you, Shagufta. So Shagufta's talked about all the challenges that we did and how we moved forward. And I'm going to talk about how we move forward in terms of getting the clinical services up and running. So the first thing, as Shagufta said, is that there was a lockdown in Karachi on March 22nd, and in Pakistan overall on 23rd of March. We had actually halted our clinical services, the elective services, a couple of days before that. On the 20th of March, we actually stopped our elective services. And then started off with screening, testing that we'd been doing. We actually had to curtail those as well. And talk a little bit about why we had to do that. What that did allow us, though, was allowed us some temporal space, some time to start thinking about how we're going to restructure the physical structures that we're going to restructure the physical structures that Shagufta talked about, reformat all the our SOPs, reformat the processes for taking care of patients with COVID within a general hospital. So we defined new algorithms, and these algorithms were for screening and testing of patients as well as employees. Our major focus was on employee health, and I think that is critically important, because if we don't have employees who are safe and healthy, we cannot take care of patients. And that was a driving force for us, and continues to be a driving force for us throughout this whole process. We came up with guidelines for PPE for each specific area, and this was dependent on the kinds of patients that were housed within that area and the risk for exposure that existed within there. And these sort of extended all the way from full Tyvek suits and N95s and face shields, etc., to gowns, gloves, and surgical masks. So everything was in line with that. We had to stop our medical students from coming to the wards. Even before the universities were shut down by the government, we had actually restricted access of our medical students for their safety. Also, we restricted them because of the limitation of PPEs that we had. So we did not want people to come in and use this very, very precious resource that we were having a lot of difficulty coming by. We collaborated with the government. So we've been working with the provincial government in our province of Sindh, as well as the federal government in Islamabad, by our experts in infectious disease, in infection control, in microbiology, in laboratory medicine, have been working with these teams. We've helped them develop guidelines and SOPs for all kinds of things, from care within hospitals to safe industry opening. Our staff helped the government of Sindh design and establish a 1,200-bed field hospital in Karachi, which now is used for housing and isolating patients who don't have place to be isolated at home. We provided testing support, and we also, what you can see in this picture is a memorandum of an understanding that's been signed by AKUH and the government of Sindh, where we will be training doctors, nurses for ICU capacity building across the province. We came up with innovations in technology. A self-assessment app, the picture of which you can see on your left-hand side, was created, and so that patients and the public in general could identify whether they have symptoms and what risk they have for the COVID infection. We've been working on innovations such as one ventilator for multiple patients in case of a surge, low-cost emergency ventilators, 3D printing of swabs, nasopharyngeal swabs, which the country was running out of. The Corona check we've already talked about on the left, as I showed you. There's an employee screening app that we have created and instituted, and this is something of a requirement for all employees within our hospital system and a university, where people are expected to self-assess their risk and exposure for the Corona infection. We've started telecommunication and teleconsultation, both for patients as well as for other physicians in the field. And also we are working towards, with the Sindh government, we're working on remote monitoring of ICUs in other hospitals within the province. So moving on, how do we get all of this to a new normal? Shagufta had talked about how we could not use this as an incident command system. And the reason for that is an incident is fairly time limited. It lasts for a few days, for a couple of weeks. This just doesn't seem to finish. And therefore, what we really wanted to do was start readjusting to this new normal, start coming up with ways that we could live with the COVID as much or as long as we needed to. So our first thing was safety measures within the hospital. And the safety measures were really for the staff as well as the patients. So what have we instituted? We've instituted mandatory screening of every patient and every attendant family member who comes with a patient to the clinics. So everybody is asked questions. They can only come into the clinic if they pass those questions. We've made masks compulsory for everybody, not just the staff, but the patients and their families as well. We've readjusted our visitation policy where no visitors are allowed to the inpatient service and only one attendant can stay in with the patient if they are required to stay in. As you can see in this picture here, there are a lot of missing cushions on our seats. And what we've done is we've removed, for every 3 seats, we've removed 2 cushions. So patients are forced to have physical distancing. Our cafeteria was changed to take away only, both for the guests who come in, but also for our staff. Our congregational prayer areas were closed, and enhanced infection control protocols have been employed. And these are not just for the inpatient areas, but outpatient. As you can see, we've got all different mechanisms for cleaning the spaces, for all horizontal spaces. We've got hourly cleaning of these areas where patients can actually be in touch with each other or touch surfaces that can act as fomites. For staff, we ensured that there was appropriate PPE available and mandated this. There's actual auditing of the use of PPE that's ongoing. We made rotational schedules for the frontline staff where they would be, for example, 1 week on, 1 week off. That would allow those, in case there'd been exposure, allow people to not get the disease itself or be identified as patients who've actually acquired the disease. And for a lot of our non-frontline staff, we've started working, getting them to work from home wherever possible. So I talked about the Sehat check screening that is done, and this is something that is a self-check that is done for all our staff. We have also implemented free testing and treatment if our staff is positive. This allows our staff to feel safe, to feel cared for. We have ensured that there's availability of full PPE, and we developed and implemented and mandated and audited the PPE guidelines. We have established hostels for our staff who require isolation and quarantine. We've created, for the areas that require donning and doffing of the PPE, we've created separate rooms at the cost of patient rooms, actually. We've created separate rooms for their safe donning and doffing. And as Shagufta talked about, the enhancement of transport services so that there is adequate physical distancing while they're transporting. We wanted our patients to feel safe as well. We've created an outside open air COVID-19 testing and screening site. This is outdoor with the air, with the wind blowing. And so it's away from clinics and other hospital areas where patients come in both by appointment as well as walk-ins and can be tested. On the left bottom, you can see this little picture of one of our testing kiosks where our employee, the tester, is within a glassed-in booth and converses with the patient who's coming in and interacts with him with appropriate distance, with gloves, and so that the exposure to these gentlemen and ladies is minimized. We do free tele-screening where people can call in and talk to our nurses and doctors and understand what their risk for the COVID exposure is, and if required, are then referred to the screening sites. Shagufta talked about enhanced capacity and development of our COVID diagnostic and treatment zone. So this is a freestanding 4-story building with single rooms. We have established within this space, we've got intensive care services, we've got step down or special care or high dependency units, we've got negative pressure isolation rooms, and we've got some special care wards as well. So this is a total of 100-bed facility with ICU. Our total ICU capacity now with this is 24 for adult, plus the pediatric patients, an additional 6 pediatric patient ICU and step-down beds that we've developed. So these required structural changes. We had to convert existing ORs to negative pressure. We now have a 3-room operating theater OR suite, which is negative pressure, where we will take in and provide surgical care for patients who are COVID positive or COVID suspect. There are electronic monitors for pressure and airflow that then again with donning and doffing areas. For the ICU rooms, we've actually created doors with glass where the nurses and the care providers could monitor the vitals for the patients without actively having to go in, decreasing their own exposure. And now we're starting towards resumption of services. When we've developed all of these facilities, these structures, these processes, we would now like to safely start care. So the outpatients. So we've got options for the outpatients. As you can see in the 2 pictures on the left, patients can be seen and discussed and consulted through teleconferencing, as well as physically. The picture at the bottom is the outside of one of our clinic buildings. Every patient that comes in, along with an attendant, if they have it, some family member who's accompanying them, are screened. They are asked questions, a risk for COVID is identified, and only after that, they are either allowed to come into the clinics or referred to areas where they can be tested and screened further by our family physicians. We've also gone on to home health solutions. We have developed home health. We've already had a home health service, but we've expanded that where there's home visits, there's pharmaceutical delivery, as well as home phlebotomy that's been created. We're also now doing pooled testing of all elective surgeries. What that means is that any patient who's coming in for elective surgery is tested beforehand within 48 to 72 hours before the planned surgery, so that we can safely assign them to the appropriate kind of surgical space and post-operative care that is required. And of course, there's full PPE for all emergency cases. So what did we learn? We learned that we've got to accept this new normal. We also learned that things that we learned needed to be unlearned, and we had to continuously change the way we functioned. So a PPE guideline that was developed now would be changed within 2 weeks' line. We saw these guidelines coming out of CDC and WHO that continuously changed. We learned that there had to be collective decision-making. And that's where that whole Higgs platform and the org chart that Shagufta showed comes in. We also realized that things had to move really fast. That had to be swift action, decisions had to be taken quickly, and we had to move into that decision because things moved really, really rapidly. Investment in staff was critical. Our staff had to know that they were safe, that they were cared for, and then only would we be able to take care of patients. There had to be a change in culture. We had to move towards understanding what we were doing and moving towards safe practice for everything and agility. We have to move really, really quickly, make the changes that are required. Thank you very much for hearing us out. We are ready for questions.
Yeah, just one or two statements that I'd like to make. Since January, where we met our teams for the first time in a town hall, which was a physical town hall in our auditorium, which has a space of over 350 people. At that day, we said, safety is priority. And to date, our overarching statement in bold letters, underlined, highlighted, is safety. So safety of our people who work with us, but also safety of all the patients who come to us. And you know, the new norm that Asim spoke about, I was the one who introduced this new norm at this institution. But I very soon realized that this is not only a new norm, it is a new world order, and we have to embrace it. And when people say post-COVID, I think COVID is going to be with us, and it is going to be with us, and we have to all figure out our lives with COVID or situations similar to COVID. And therefore, embracing this new thing within us and accepting and moving on is important. And therefore, you saw how we are working on resumption of service. And that is the thing that I did not say at the beginning. It is not an incident. It is something which is going to be and which is already part of everything that we do. It is something which is present. The only thing different with this is it is everywhere. It is across all disciplines, it is across all spaces. And therefore, this thing has taken us all by a big surprise, and we are still learning. But I would like to take this opportunity to thank my teams here. Thank the management, the leadership who trusted on us at the back end of the hospital to lead this, and all our teams at the Aga Khan University Hospital, the Medical College, and the School of Nursing and Midwifery, who rose up to the challenge. And they have been steadfast and resilient and hardworking and have never lost hope. So their hope and their resilience and their hard work has helped us do all what we've been able to do. Thank you to the team at the Aga Khan University, and thank you to the IHF. Thank you. Over to you for your questions.
Thank you very much for your presentation, and especially for ending up sharing all the spirit and the importance of having common values in the healthcare community to move forward. Also, your key messages and learning showing how it is important to be pragmatic are very insightful comments that I'm sure the participants will take home. A few questions here to start with. One first question is related, you mentioned quite quickly that you did telemedicine, and that's one of the alternatives, by the way, in the new normal. Could you elaborate a little more how you articulate your place as a referral tertiary hospital with the secondary and the primary care services in the way the response to the COVID has been organized and potentially the new normal is looking ahead?
So thank you for that very interesting question, I must say. Teleclinics is one project on which we as a hospital were trying to work for the last 2 years. And what COVID taught us is that this is now a must to have rather than an option. And therefore, the learning on this one was very swift. We're using the platform. We already had a platform available that we were toying around to ensure that we are able to introduce it. So we're using that platform. Right now, from the secondary care hospitals, the referral happens for any COVID patients who come to our secondary care sites or the primary care sites that are COVID positive are either physically referred to us or they are referred and asked to make a teleconsultation appointment. And then the teleconsultation appointment happens here. We are still implementing it. The percentage of clinics, if you want to understand, is less than 10% of the total volume that we have in the overall grand scheme of affairs. But we are working on ensuring that in the new norm, if we want to do the level of activity in the clinics, for example, you saw 1.4 million clinics a year. With the social distancing, it will not be possible to do it at the main site physically. And therefore, what we are looking at is a combination of home-based, tele, and physical consultations.
Yeah.
Asim, you want to add something?
I just wanted to add that, starting the teleclinics and teleconsultations is not just a cultural change for the physicians and the care providers. It's also a big cultural change and acceptance problem for, or acceptance issue, not necessarily a problem for the patients themselves. And I think some of them have embraced this beautifully. They love it. Whereas others just find it very strange. Yeah. So I think that's also a learning that we will go through as time goes on.
And also payment options, like, many people do not have a credit card. So we had to adjust ourselves to come up with the easy Pesa options or the, easy money options that are there across the country. So we are also learning and we are also improving by the day based on the learnings. There's a lot of feedback that we get. The clinic did not start on time. The doctor was not there on time, ended soon, ended too late. And what we're doing is we are trying to capture all the feedback. And every week, the feedback that comes is given down to the teams for their improvement. And this feedback is helping us adjust and bring about improvements.
So this is just outlining all the aspect of providing virtual services and as part of the new normal. What about the referral system? I don't know how it is in place. It was in place before the COVID crisis, but did the COVID crisis impacted the referral system? Do patients come directly to the hospital, university hospital, or are they usually coming as referred by secondary or primary care?
So very good question. Our 4 other hospitals, 3 of which are in Karachi, the same city as the tertiary care, quaternary care hospital is, and one is in a city which is 100 miles or 200 kilometers away from the city of Karachi. The referrals that usually come is through an organized mechanism where, because those are primarily maternal and child care hospitals, if a patient, and these are secondary care sites, so if a patient is more complex than that can be handled there, they are referred to here. With the COVID situation, what we are also now doing is there's a screening for COVID patients that happens at these sites. And because those 4 secondary care hospitals do not handle COVID patients, they are all being referred to the main hospital through a mechanism of referral that we have. So all COVID patients are then referred to the main tertiary sites. As far as the primary care centers are concerned, they are not treating COVID as of now, and they continue to do their normal work. And on a daily basis, if there is, for example, a GI clinic that is happening, and if there's a patient who requires a tertiary care consult, they are referred through our internal mechanism, through an appointment system, to be seen here. And now, since we have another option of, other than physical consultation, a teleconsultation, patients from other cities of Pakistan find it more convenient, because now they can do a teleconsultation, which is previously our doctors were traveling to other cities monthly. Now this is happening through a teleconsultation.
Yeah, okay, that's giving a good understanding of how it works. If we go on the, I would say, business side and also on the accessibility, as you are a private organization, you are funded, I guess, by fee for service. So how did it work with the COVID? I guess that the patients that have the test, the patients that have to be hospitalized have to pay for that, and is it affordable for them? Did you had to revise the way you are pricing it? Did you receive special funding for that? And how potentially the new measures that you have taken for the new normal is going to affect the business model? Because with the social distancing that you described, obviously you cannot have the same flow of people within the facility to be treated.
Very interesting question. As I showed on the graphs, our hospital occupancy, which was in its 80s, dropped down to its 20s, and now is back in its 40s. So we, as you know, that one of the reasons for disbanding the HICS system was that when we were only talking COVID within the institution, people were only focused on COVID. And I, sitting in my seat, had to ensure that people start talking about everything else, because at the end of the day, COVID has a very finite bed capacity in the hospital. It is an 800-bed hospital, and 100 beds are COVID beds. So we had to talk about the remaining beds which are there, and therefore the HICS system was disbanded. And we've been doing multiple discussions with the people on resumption. But what we've done is, and we are working on a grid with people. So to get to the targeted number of volumes, because you're right, we did not get any funding. We are a fee-for-service institution, and we do not get any operating grants on the one hand. And on the other hand, we have a very large component of what we call a patient assistance program, which we call a patient welfare program. And the annual budget for that is over $20 million. So there's an annual patient welfare commitment and spending by the Aga Khan University Hospital of $21 million, which is a huge commitment. So what we've done is that we've made a grid for people, and that grid is basically how much of the clinic volume, say a service is doing 1,000 clinic visits per month, they are now telling us of the 1,000, how much of that will be achieved on an in-person, how much is going to be teleconsultation, and how much of it is home-based. So people are making their grids. Those grids at the back end are by physician level defined as to which physician is going to do which component. Because unless we map it at that level, we will not be able to get to where we are getting. And because we are private, because we do not get any grants, any operating donations, it is very important that we are able to sustain through the crisis. Sustaining through the crisis is very important. And our teams are now really focused. As I said, the occupancy that dipped down in its 20s is back in its 40s. So the graph has again started to move north, which is a very good thing. And all our teams are now focused to see how through a combination of services, Asim spoke about home delivery of pharmacy. That is one area that if people can't come to us, no problem, we go to them. Home lab sample collection, you can't come to us, we come to you. So we are trying to ensure that we are able to meet the needs of the patient. We're also working on communicating with our patient fraternity, patient community out there and everyone else as to how our campus is safe, because we have really invested a lot in ensuring that there is no commingling of COVID patients with the other patients, the spaces are safe, etc., for the staff, for the patients. So we are now getting into a campaign, a communication campaign for all our users to ensure that they trust safety and we are able to demonstrate to them how we will work in a safe environment. But Eric, the simple answer is that, as I said, that this is the new world order, and each team back end is trying to figure out how they will be able to make up to what they were targeted to go to. Because if that is not achieved, if that top line doesn't come, then something has to let go. But we've also reviewed our expenses, and we are looking at, for example, all international travel as it is stopped, so that line goes away. We are reviewing training budget requirements. We are looking at entertainment budgets. So all discretionary spending that we have is stopped. We are not doing any new recruitments other than extremely essential staff requirements. So we are looking at the expense front, and we are looking at maximizing revenue and to ensure that as much expense as can be curtailed is curtailed.
So if I may add one thing also, is that Aga Khan University Hospital really has always been a place where the sickest of the sick come.
Yeah.
So this has been a referral center for referral centers in Pakistan. And one of our biggest concern was that this population of patients would be left. And what we would get is much more morbidity and mortality, not in the COVID cohort, but in the non-COVID cohort. Patients with cancer, patients with diabetes, patients with other illnesses that require treatment for their illnesses, but either don't have the access to care because the clinics are closed or the elective surgeries are not happening, or because they're afraid of coming to hospital because they may get COVID. And so those are the things that we wanted to do. So the first thing we did was change, as I showed earlier, is change the way we practice, making it safe for patients and staff. Shagufta just talked about our information campaign for our patient populations, ensuring the safety and the processes that we put into place, and then restarting or kickstarting care for non-COVID patients as well.
You know, we have developed protocols, for example, for if a woman is booked for us to be delivered, there is a complete protocol on how we screen them. And if that same person requires a testing, how many days before the delivery is the testing done? So we are developing by service protocols to ensure that we do a complete workup and that we keep our environment safe. So there's a lot of back-end planning working that's happening to ensure that even the teams who are on the ground feel that, yes, it is safe to work here as well. The physicians feel safe, the nurses feel safe. And if they feel safe, they're able to deliver safe care to the patients as well.
Yeah.
Yeah. So for example, these protocols, do you have them also for the selection of patients for teleconsultation and also for the patients to be aware of the limitation of teleconsultation? Is it
Yes.
organized in a specific way?
So when people call for an appointment, our call center asks the questions, and if the service can be delivered, because everything can't be provided teleconsultation, so there is a mechanism of screening. Whichever patients are able to be seen through a teleconsultation are provided that appointment. So yeah, there is a complete protocol for that as well. For COVID, for example, there is a free screening that we are doing, because we had a lot of worried well that were coming to us for a test, and the number of tests available in Pakistan is very limited, and we really did not want to use this scarce resource for the worried well. And therefore what we've done now is there's a free screening. So there's a tele screening that happens for people who want to come for a test. If that tele screening does in fact require a test, then people are referred to our testing site. So we are ensuring that we are making optimum use of the limited resources that we have.
And also for the teleconsultations, we've really left that to the individual service.
Yeah.
I can tell you, for example, in my own pediatric oncology, we're using teleconsultation a lot for our follow-up patients, where patients don't necessarily have a comfort level with the physician, don't necessarily have to come in. They can do lab tests at home. They sit down and talk to us. We tell them whether to increase or decrease or when to come in for their chemotherapies, etc. However, where we believe that they need new patients, for example, where they must come in, get a physical examination, etc., we are recommending that they don't utilize teleconsultation. So it's really left to the services themselves.
I can quote an example, a person in my own family who is an elderly patient could not be brought here. So this patient was provided a teleconsultation, followed by a home lab specimen collection, followed by a home pharmacy, followed by a home physiotherapy, and again followed by a home nursing care. So this complete patient care is now available in the comfort of the house of the people as well. It is the choice that the doctors also do not want certain kind of patients. If they can be treated in the comfort of their zone, then that is what we are looking at. Patient is at the center of it. And the patient is at the center, the safety and comfort of the patient and the experience of the patient is our priority. And we are trying to readjust our services to ensure how we are able to meet their expectations.
Thank you very much. I mean, you have provided, I think, a lot of very interesting examples and situations that can really give insights and ideas on how to move forward. Unfortunately, we are coming to an end for our webinar, and let me give you a few takeaway messages that I've heard from your presentations, and please feel free to complement them before we end this webinar. So the first one I took was that if there is an existing emergency response system, it's always good to leverage it because it allows immediately to have the capacity to put in place the response. But while doing that, it's also very important at the early stage to really have the customization of it, because the situation we are facing might not be the one that the system was designed for. The other quite important message is that a new situation requires that very early the specific challenges related to this new situation are well recognized so that there is really an adequate response to these new challenges in place, so that there is a continuous, learning implementation cycle in place. The third one is that it's amazing how hospitals can be flexible. So we often consider the hospital like, the Titanic, big steamers that are going on their way. But we have seen, for example, in how you have adapted that, the buildings, the equipment, the people, all that can really be adapted to unexpected demand. And in this case, it's also amazing to see how the adoption of change is going at a high speed, while we have the tradition in hospitals that it is always difficult to make changes, the culture of the hospital is rather a culture of cautiousness when it is about change. But when we see that there is really a threat, everybody is behind, and the adoption of change is really happening rapidly. The other one is definitely on collaboration. It's a critical driver. And what is also amazing in what you have demonstrated, when we talk about collaboration, is not within the hospital, which is very important, but here it's really an overarching collaboration, breaking all the boundaries between the type of industries, between the different type of authorities, and between the different type of stakeholders. And what would be interesting is to see how much this overarching collaboration can be harnessed in the future for the transformation of healthcare. And the last one that you have really insisted on, and that is a critical card, is the people. It's very important, of course, to take care of our people, the staff of the hospital, the healthcare worker, to support them. But what you have also shown, and that's quite an interesting and important balance, or the two sides of the coins, is that while it's so important to support the staff, to enable the staff, to protect the staff, it's also very important that the staff has his own individual responsibility in regard to his or herself and the rest of the community they are working in and for. And so the combination of protection and responsibility is also very critical for a successful response in a situation like this one. So these are some key overarching messages that I took away from your presentation. If you want to complement, please go ahead, and I really thank you for all your insights and your very interesting experiences that you have shared.
I think the only thing that I'd like to add is that this is going to be a journey which is not going to be short. The journey is going to be there, and there's a lot of learning. And our teams, the teams who work on the ground, the way they work, the way they adapted, adjusted, unlearned, learned, relearned, and relearned was incredible. And you know, in times like this, you see the true making of the institution. And I'm very, very humbled to be, you know, the interim CEO of this very unique team of very hardworking, very committed, dedicated professionals. So I'm extremely grateful to the entire team who I represent at this forum, to thank them. I can't thank them enough for all what they have done and what they continue to do on a daily basis. Thank you, Eric. Thank you.
Thank you very much. I think I totally agree with what Shagufta has said about the team, the people working within the institution itself. I think one of the things that's really, really important is involving the patient, keeping the patient in mind, ensuring that information continuously is sent out of the hospital, so that the anxiety level of the individual patient and their families is alleviated. And I think that communication bit is extremely important. Shagufta talked about that was external, but also internal communication. Shagufta talked about a town hall that we done in January. And although that was our last live town hall with real people sitting there, we've actually had 6 or 7.
More than that.
I don't know.
We've done a lot of town halls.
Of virtual town halls. For either the general population, or for nurses, or for students, or for residents and postgraduate education, trainees. Yeah. So we've continuously involved different people along the way. And I think that's really, really important.
And I think the impact of the university, the one very important piece that my own learning is that, what is the impact? There's one impact that we are doing for the patients and our people. The larger impact that we were able to do is with working with the government, and the kind of training that we are providing. We are training intensive care doctors, intensive care nurses that work for the public sector hospitals. And that's a very large impact that we are able to do by training the doctors and nurses at large who work in the public health system. We can't go everywhere, but if we train those people, there's another project, a tele-ICU project, and maybe the dean can one day come and talk about that tele-ICU project, where how there is a group of tele-ICU consultants from across the world who are our alumni, are available through teleconsultation for the public sector hospitals. That's also very high impact. So we are trying to see that people who come to us, we are able to make a difference in their lives. But how does this small university, which is in Pakistan, which is there, can make an impact across the country? So we are working on both the fronts. Yeah. And a lot of innovation has come in through this. And, you know, very small example that we used to do continuing medical education program for referring physicians from across the country. And we used to do 100 of them. And every continuing medical education program would have 50 to 100 people. The first CME program that we did online, it had over 1,000 people. So the power of technology and the power of access that we can create using technology is enormous. And I think that potential also is a huge potential that can be leveraged. Thank you, Eric. Thank you.
Thank you so much for sharing on this knowledge and finishing on the note of spirit. It's also very important to have a strong spirit and positive spirit in what we are doing. Patricia, the floor is yours for the concluding information.
Thank you, Eric. Also, thank you, Shagufta and Asim, for the very informative presentation. Really enjoyed all the insights that you shared. To everyone, just a reminder that we will be posting the video recording of this webinar on our website, and we will notify you by email when it's available. We still have a few webinars signed up in the next few weeks. The schedule is now posted on your screen, and if you would like to join them, please just register. Go to www.ihf-fih.org/webinars. So next week, we'll have a panel session which will be facilitated by Dr. Alexander Precker and will include experts from the World Bank, Columbia University, and Office of the Global AIDS Coordinator, who will discuss the challenges the health community is facing due to the COVID-19 pandemic. They will be bringing to the table over 30 years of experience working globally on major epidemics and discuss lessons learned from low and middle income countries that are relevant to the more developed countries of the OECD. So we hope to see you there. In the meantime, please stay safe and healthy. Together we'll overcome this crisis. Thank you again for joining us today. Shagufta and Asim, thank you very much again for your contribution.
Thank you.
Thank you, Patricia.
Thank you.
Thank you, everyone, and good evening, good day, good night.
Bye-bye.
Bye, everyone.